Okay, the next topic we're going to talk about is urinary tract infections in pregnancy. Here's our case. A 23-year-old gravid 01, 31 weeks gestation, complains of flank pain, nausea, vomiting, shaking, chills for 12 hours. Anytime you have a patient who is pregnant who has flank pain, you better think of a pyelonephritis. Which side is more common? Right side, 90% of the time, because of the enlargement of the uterus, which brings about the ureteromegaly and the increase in the renal pelvis size. So she has flank pain, she has sickle cell trait, and there we have the increased risk of urinary tract infections with sickle cell trait. On exam, she has 103 degrees fever, her pulse is elevated, respirations are elevated, her skin is grossly diaphoretic, she has exquisite right costovertebral angle tenderness. What do you think her insensible fluid loss is? With a high fever, with high respiratory rate, and with sweating. Many of these patients are significantly dehydrated, and they need to have a couple of liters of IV fluids in order to retain or to return their urine output to normal. Electronic fetal monitor tracing shows a baseline heart rate of 170. Normal fetal heart rate is 110 to 160. If mother's temperature goes up, what do you think happens to the fetal temperature? The fetal temperature is always half a degree to 1 degree higher than the mother, because the mother is a heat sink that transfers the heat from the baby to the outside. So the baby always has to be warmer than the mother. So here we have a fetus that probably has 104 degrees, and what effect will fever on the baby have on its heart rate? It's a physiologic tachycardia. It has reactivity, which means that there are accelerations, so that's healthy, but there are contractions. And preterm labor is common with patients who have pyelonephritis. Let's look at UTI in pregnancy. There are basically three entities we're concerned with: asymptomatic bacteria, acute cystitis, acute pyelonephritis. The most common is asymptomatic bacteria. What are the symptoms of asymptomatic bacteriuria? Duh, there are no symptoms. So she doesn't even know she's got it. How do you make the diagnosis then? A urinalysis and culture sensitivity. And that's why on the first visit, prenatal visit, we always do a urine analysis and culture. This is localized, not systemic. Untreated, 30% of these patients go on to develop pyelonephritis. And that's why we want to screen for these patients. 8% of pregnant women. If there's 4 million births in the United States a year, that is 320,000 women with asymptomatic bacteriuria in the United States. Management is outpatient, oral antibiotics. And a good one to use is nitrofurantoin. E. coli has not developed resistance against this. It is concentrated in the urine, and it can be very nice in pregnancy. Acute cystitis, 1% of patients. Urgency frequency burning. This patient will not allow you to forget that she has an infection. She'll call up and say, "Doctor, the pharmacist says they haven't got the prescription from you yet." This is also diagnosed with a urinalysis, and CS is culture sensitivity. This is localized infection, not systemic. Again, the concern, if it's untreated, is pyelonephritis, and this can be managed with outpatient oral antibiotics. One of the severe medical complications of pregnancy is acute pyelonephritis, 1 to 2%. That's 40 to 80,000 women in the United States. This is associated with fever, costovertebral angle tenderness, right side more than the left. We're going to do a urinalysis and culture sensitivity. We're going to see white cells. We're going to see gobs of bacteria in the urine. And this is a systemic disease. A systemic disease. Have I talked to you at all about the lipstick sign? Let me talk to you about the lipstick sign. We have two patients, both pregnant, and both say, "Doctor, I'm really feeling bad." One patient, her hair is nicely done. She has makeup on, she has mascara, and she says, "Doctor, I'm feeling bad." The other patient, her hair is not done. She has no makeup on. She looks like a scarecrow. She looks like she just got up in the morning. Which do you think is more likely septic? The negative lipstick sign or the positive lipstick sign? Now you can tell from the door. The negative lipstick sign I'd be far more concerned with. And these patients can very well have a negative lipstick sign. They look septic. Bacteremia. If you did blood cultures on these patients, 20% would have bacteria in the bloodstream. And we've seen more than our share of patients with acute pyelonephritis who end up with adult respiratory distress syndrome, and they're in the ICU on a ventilator. Why is this? Because of toxins from the bacteria that injure the capillary alveolar membrane in the lungs, and they get ARDS. These patients can be sick. This is inpatient management, IV antibiotic, and you notice I've got the S here. If she is uncomplicated positive lipstick sign, we'll probably just give her some IV cephalosporin. But if she is a negative lipstick sign, if she looks septic, I'm going to give her gentamicin as well as cephalosporin. Here's your nitrofurantoin. Resistance is futile. Excellent medication to use other than toward delivery. And the most common organism is your gram-negative rods, E. coli. And that's the end of urinary tract infections, pyelonephritis, and bacteriuria in pregnancy.